VAAFT or Video-Assisted Anal Fistula Treatment is one of the latest and most advanced way of treating fistulas. Why it is better than any of the other blind technique? Because you are seeing the thing and then you're ablating or removing it. And obviously and logically, it cures the problem more than what we would have otherwise done if we do it blindly. Now, VAAFT consists of two parts. One of the part is called as diagnostic one, which is a fistulascopy. We put in this scope inside the fistulous tract, like what I'm doing now. We'll just go inside the tract. We'll try to assess the tract, how deep it is. Is there any side branches? Where exactly it is opening in the anal canal? And that is the internal opening which we come to know. If there are any side branches, we'll see those pouches which are coming in the view as I go in, and that I can tackle them as I treat it when I'm doing the operative part of the VAAFT. If there is any chronic abscess, then we see a little wider cavity. If we do a blind procedure, then these cavities can be easily missed. The side branches can be easily missed, especially when we are doing a sphincter saving procedure where we are not actually cutting and ablating or removing the tract completely. Now, once the fistulascopy part is complete, before we finish the fistulascopy, we locate the internal opening, stay sutures in that area, which will guide us for a closure at the end of the procedure. And then we remove the scope and come out, and we do a operative part of the VAAFT technique now. Now, suppose we have come out of the tract, we see the external opening. If it is not wide, we make it a little wider. We go in the scope again. And then afterwards, what we will do, we'll use one of the energy sources to burn the granulation tissue inside, which is the main culprit in causing the fistula one and not allowing it to close on itself. So what we can use is, there is a coil-like thing there, what we call as a electrocautery, and this particular wire, it can go through the scope inside, and again, as I said, this will go under vision. So once we start threading it through the sheath in the scope, it goes all the way inside, and then it will come in the view. So once I'm putting it inside, you can see it. In some time, you'll see a projection which is jutting out of the scope, and that is the area wherein we need to start burning the tissue. Can you see this thing which is coming out? So now once this probe or this ball-like thing comes in the view, we can start firing the energy, and that can burn the granulation from inside. Once we have burned the granulation from external opening to the internal opening, then we can remove that debris by using a brush. We are talking about the advanced procedure. Electrocautery is one of the very old method of coagulating or removing the tissue or cutting while doing conventional surgeries. The laser is the latest kid on the block, and this is one of the most effective way in treating fistulous tracts and pylorhinal sinuses, because not only it will ablate the granulation tissue which is causing the problem inside, it will also shrink the tract. So if we are using a wide tract, and then when we fire the energy, it will further shrink it, and that will hasten the healing. So that helps in the healing. Rather than using a cautery, if I use this laser fiber instead, then what I do is I will put in a radial fiber inside. This fiber goes in through the same sheath as I am looking inside using the scope. And mind you, this is the magnified view of the fistulous tract. The 5 mm thing will seem much larger on this screen. And as it comes out, you can see this is the probe which has come out. Once we start firing the energy, we have to make sure that we protect our eyes. And so I'll take some time to put it back inside, and this is how it goes. You're still seeing the fistulous tract, and here comes the laser fiber. Once I put it on a particular setting, we can start firing the energy, and that will burn the fistulous tract. So we start using the laser energy to burn the tissue inside, and you can see the thing is getting burned, and that is being done under vision. As we keep on doing all around, from the external opening to the internal opening, we can burn the fistulous tract completely from the external opening to the internal opening. And then After we have burnt the tract using a laser fiber, what we are going to do, we'll put in a retractable device called as a brush or fistula brush, and that goes inside through the same channel. When we are working in a real life situation, that time we are washing the tract using a solution of glycine or with normal saline. And once this thing goes inside, we can put the scope again, and as the brush advances inside, you can actually clean the debris which you have created by using laser or by lasing the tract. Now, this particular thing is very important because if you leave the debris inside, it is going to cause the problem again and it will become a nidus for a recurrence. So, this fistula brush is a very important instrument when we are doing a VAAFT. Now, once we have done this, and there is a possibility that a part of it is not coming out just by using the brush or by flushing it with the saline, when you try to push the whole muck inside the anal canal, then we can use this kind of a pickup faucet. This faucet goes inside, again through the same channel. You traverse the whole area, come out, and then you can open the jaws and take out the debris which is causing problem in that particular region. So these are the various energy sources and the device which we use when we are doing VAAFT. Once we do this, we will do a fistuloscopy again to see that there is no area left in between. From the outer opening to the internal opening, we have ablated the whole thing, we have burnt the tissue, we have cleaned it using a brush, we have removed any specks of tissues which are lying there, and then we flush the tract completely. And now what we are going to do is the stitches which we have left behind on the internal opening, either we will close it or we'll do a flap to cover the internal opening. In cases where we are doing a sphincter saving procedure, it is very important that we close the internal opening because that is the main feeding part which is causing the fistula, and it can be the cause of a recurrence later on. So it is better to do a stitching of that tract, or we can also do a flap surgery as I told you. So this finishes the VAAFT procedure. If you have a fistula and you want to know whether VAAFT is appropriate for your kind of fistula, visit some specialist who does this particular surgery and then ask about it, because VAAFT may not be suitable for all the patients, but the patients who are having a fistula which is opening little away from the anal opening, maybe in the gluteal region, maybe in the thighs, and that is where this particular technique is very useful because we can avoid creating large wounds which will take months together to heal. So if you have this problem, VAAFT is one of the most effective, latest and advanced treatment as of now. Thank you.